Hi, everyone, and welcome to another episode of the Rehabilitationist podcast with me, Alex Murray, the Rehab Podiatrist. I'm very excited for today's podcast because I get to talk tendons and specifically the posterior tibial tendon, and I get quite selfishly to ask an expert all of my clinical questions, things that I encounter in my practice, and hopefully you'll get a lot out of these questions as well. So let me introduce my guest. If you don't know him already, it's Professor Peter Malliaras.
Hi Alex, how are you?
Yeah, doing well. Thanks so much for coming on and having a chat. So,
No worries, thanks for having me.
not a problem. So, whenever you look at tendon research, people are going to know your name. They're going to see it. But for the people who have somehow managed to miss it, can you tell them a bit about yourself, who you are, and what you do?
Yeah, sure. So I'm a physiotherapist. Been a physio for 25 years. I work, I've sort of mixed clinical practice with research over that time. And at the moment, I'm a professor at Monash University where I'm there full time. And then I also see patients 1 day a week, and that's mainly. It's mainly looking at difficult persistent tendon cases, mainly from the lower limb.
Amazing. So you've got a really great mix of research and then getting to see it and put it into practice.
Pretty much, yeah. It is nice to be able to do that for sure. Yeah, that's part of the fun of what I do because you're you're doing research and then you're trying to apply it, but it also works the other way where you've got. I think your research questions are very much influenced by what you're seeing in a day-to-day practice.
That's very good, and it's sort of like the ultimate when we think about knowledge translation. Sometimes you can be a bit separate from the patient population you're trying to see, and so yeah, you get that nice sort of I hate the word, but synergy.
Yep, yep.
So I wanted, like I said at the start, I wanted to get you on to talk about the posterior tibial tendon specifically because when we just search posterior tibial tendon, just looking about what people are talking about, it's not a big tendon to talk about.
Mm,
Everyone's talking the Achilles, the patella, the hamstring, which understandably because they are probably the more commonly injured tendons and the ones that will probably see the widest applicability to people with learning. It's also the ones we have the most. It seems to have. You can correct me if I'm wrong. The most research. So I guess my question to you to sort of start out the gate would be, if we're thinking about all of those other tendons and the posterior tibial tendon and comparing them, what's similar and probably more importantly, what's different about the posterior tibial tendon that's going to really impact assessment management?
mm. So I think there's probably more similarities than differences. I think that's probably the first point to make. There's when you're looking at tendinopathy, the pathology is quite universal, and it's even the presentation is quite similar. You're going to have localized pain. You're going to have load-related pain. So a lot of it is quite. There's probably more similarities than there are differences, and also with a lot of the managements with tendinopathy, there's going to be similarities in how we manage them. The probably from a difference point of view, there are also some differences to highlight, and that is the population. So we tend to see tendinopathy in all sorts of people, young people, middle-aged people, older people, whereas with tibialis posterior, you do see a lot of the older end of the spectrum, and that's because it is more of a disease where it might be related to, well, I guess the most common presentation is in the acquired flat foot person where they're starting to get changes in their tibial tendons plus their joints, and that's an age related problem. So there is that real clear connection with aging that you see in tibialis posterior. Um, Not that you don't get tibialis posterior in the young folk, you do, but it's not as common as, say, Achilles or other things that we see. So I think if you take the population, it's probably a little bit like gluteal tendinopathy in that way. It's a very specific population. Gluteal tendinopathy is the perimenopausal females, and it's quite common in that demographic. And it's the same with tibialis posterior. It's really common if you look at those older that older demographic. Um, so that's probably a key difference. The other difference is there's clear biomechanical elements because it's a coronal plane tendon as opposed to the Achilles, the hamstring, and the patella, and also the plantar fascia that are all sort of a sagittal plane tendons. So there's a difference in the function, and that also leads to differences in how we think about tibialis posterior and how we manage tibialis posterior. Uh, probably the other key difference is that tibialis posterior has a tenosynovium as opposed to the Achilles, the hamstring. They don't really have that sort of synovium around them, so they don't have those synovial cells that can really lead to real inflammatory fluid responses. You do see it sometimes in the Achilles, but it's not that common to have lots of fluid around the Achilles. Whereas with the tib post, it's really common to see lots of fluid around the tib post, and that's your tenosynovium problem. So there are some key differences. There are some differences in the way that we sort of view tib post.
It's funny because you said, oh look, there's probably more similarities than differences, but I can see your point in terms of over the majority, but then it's just those sort of three things that you've highlighted, especially I think the tenosynovium and the fact that it's a tendon operating in the coronal plane. Thinking about and then also the biomechanics component of it, I think really can really change exactly how we have to think about it. Because I guess you've sort of preempted already a couple of questions that I have. One of the big ones was about this about tenosynovitis specifically, because one of the ways that I see in clinical practice is that there's some people that present with mainly tendinopathy changes, so like a degenerative tendinopathy. There's some people that then turn up with a mainly a tenosynovitis. But when I look at some of the research, it often talks about the actual condition starting with a tenosynovitis and then working into a degenerative tendinopathy. And I guess my understanding of it was kind of we're dealing with two separate kind of conditions in a way, because a tenosynovitis can almost come from shear forces rubbing like it's the protective sheath and irritation, and then the tendinopathy itself is more of the load related. But I guess there's this implication that they're sort of more on a spectrum of a continuum, and I guess I'm wondering what your thoughts and experiences are.
Yeah, it's a good question. I think we don't really know if there is a continuum. Like you've explained, is it that you get tenosynovium, and a bit of fluid in the sheath first, and then it sort of progresses to something else, like a tendinopathy, or is it the other way around, or is there just mixed presentations, and it just depends on the individual? I don't think we have a good handle on that. Certainly, there isn't really any research that is suggesting that it is one way or the other. So it's the way that people present, in my experience, is they can present quite commonly with a mixed picture of fluid and the tendon, or they could have just the tendon. And some people have just the fluid in the sheath, but in my experience, that's a little bit less common. So unless it's a very small amount of fluid, so that's sort of the ones that I guess I'm seeing more of, the ones that have got a mixed uh, presentation of fluid in the sheath um, and a little bit of tendon pathology. Um, but I don't think we have a really good handle on how it sort of develops over time, what comes first, those types of factors. I think the presentation is different though. So if you think about the ones that have just tendon, they usually have pain that is very localized, either at the insertion of the tibials posterior to the navicular, or they can have pain at the medial malleolus, and they're the two sites that you sort of get compression. You get the insertional type compression at those sites. So it can be quite localized, and it can be very load related as well. So there's a bit of a better load to pain relationship, where the more you load it, the more pain there is. Whereas with some of the tenosynovitis, some of the sort of fluid in the sheath, there might be more of a diffuse pain presentation across that whole area, and there also might be a less clear load to pain relationship. So you load them, and it might be painful, but regardless of the type of loading you do, it's just the same pain, rather than a real close relationship with how much you're loading. So there are differences, but I think it really does depend on the individual. Once you get to that, we talked about the acquired flat foot conditions, where you do get some quite severe changes in the tendon. The tendon can be quite thickened, and you can get tears in the tendon, and they often have got a lot of fluid around them as well, because they're really progressive tendon degenerative type conditions, so they do get the fluid around them. Um, so yeah, I'm not sure if that answers your question.
No, no, no. I think that's quite good because it's clarifying what we're dealing with. But I guess you're highlighting exactly the way that I was thinking about it, which is that they are sort of two. They do sort of present slightly differently, and I definitely see those cases as well where someone comes in and the pain is
Mm,
really diffuse. You load them, you unload them, you kind of like do lots of different things, and it's always irritable compared to that direct sort of loading relationship. And it does kind of make a lot of sense if we're thinking about
mm,
it being the sheath being irritated and fluid, and then just sort of any sort of amount of movement, because there is it moves around the tendon itself moves around the malleoles. It makes a lot of sense for it to be any sort of movement where we're getting that rubbing, shearing, a bit of compression is going to be irritable compared to a dose response relationship with load, which is what you've
mm,
explained we see in
mm,
most tendinopathies.
mm,
Is
mm.
the way that I've thought
Yeah.
about sort of managing the fluid and the tenosynovitis more so is trying to sort of settle it down more acutely. Not thinking about it like a reactive tendinopathy, thinking more about how do we just reduce that irritation for a period of time. Maybe it is more anti-inflammatories. It is sort of that the wrap people always talk about. The anti-inflammatories, hydroid cream sort of combination. Wrap it up, let it
Mm,
settle. And I guess
mm,
one of the things I think about with
mm,
your clinical
mm.
practice being that you're seeing the really difficult tendons, I guess is there a possibility that from what you're seeing in clinical practice is that if an isolated tenosynovitis might actually be easier in that sense to manage and why it might not get to you, and do you see this kind of acute um, management
Mm,
with
mm.
anti-inflammatories and a relative period of rest being potentially effective for that, or are there
Mm.
some questions about that kind of management?
Yeah. Um, it's something that I've thought about quite a bit and played around with as well. It's it's there's certainly no evidence that that type of hydroid and topical anti-inflammatory mix does have an influence on some of the fluid that you see in the tenosynovium. And what I've done in my practice, and this is just anecdotal experience over the last few years, seeing these people, I use ultrasound imaging in the clinic. So I can have a look at the tendon and see what amount of fluid there is, and take some measurements of fluid around the tibials posterior. And what I do with patients is then send them away and do the hydroid and the topical anti-inflammatory aggressively. So every day, plus they do reduction of their irritating activities, and also footwear advice and other things that you would do. Uh, and to be honest, I haven't seen any real difference in the fluid. Um, you do you do see. I'd love to say. I'd love to sit here and say, and it works. You know, it really does make a difference. But I haven't seen any difference in the fluid. If I send them away for a week or 2 weeks and they do it every day, and then I get them back. Now, this is just anecdotal, and this is just my experience and on a small number of patients. But um, when I have tried that approach, it hasn't made a difference. What does make a difference is making sure that you're getting on top of their activity. You're looking at all the activities they're doing that might be affecting that tibialis posterior region, and it's usually the walking activities, some of the sporting activities they might be doing. It's usually walking because they're that demographic. Usually, walking is the main factor for them. So it's looking at all those activities they're doing, trying to get on top of those activities. It's getting them into the appropriate footwear. It might be an orthotic solution as well that you're getting them into. It's doing those things over an extended period of time, and it's more like 3 to 6 months that really targets the fluid. So I think we've got to be careful when we're saying, is the fluid acute? Because when they come to us, it's really hard to actually judge how long that fluid has been there for. It might be that that fluid has been there for several months before they've been symptomatic. So, so this is the trouble that we have in clinical practice. If their pains come on, their pain might have come on in the last week or 2 weeks or 3 weeks, and they've come to see you, but we really have no idea about how long that fluid has been there for. It may be that fluid's been there for some time, and we know that pathology tends to predate the onset of pain, sometimes by several months or even years. So um, it's probably the same with fluid. That's my impression. That sometimes it's clear. Sometimes you get someone who their history, they might have done something that, you think that is maybe very much likely to have flared them up and caused some increase in fluid. Other times it's not that clear. So, yeah, it's always good to have a bit of skepticism about how long that's fluid been there. And I think that partly contributes to the fact that I don't think we can get rid of fluid very quickly or easily. And even if you do things like injections, it doesn't get rid of the fluid. So people have steroid injections sometimes, which we'll probably get to. I don't advise that people do go down that path.
You're answering a question I
But
have. Yeah.
if they do, um, and you look at them with ultrasound again in the following weeks, again the fluid is not resolved. So my clinical impression is that fluid does not resolve quickly, and it certainly doesn't resolve quickly with things like hydroid and the wrap. Now I'm not saying don't do them, and they're not effective, but I think we do need to be aware that probably the longer term strategies of getting the right type of loading under control, and getting the right capacity in that ankle and in those foot tendons to deal with the loading is probably going to be the thing that over several months is going to have the greatest effect on the fluid that is in there.
Yeah, I guess that the follow up sort of to this about specifically anti-inflammatories, injections, or like all of those other sort of treatments, is you're saying it's not good for fluid and it's not good for reducing that down. But would it be? Do you see some benefit to symptoms? So while an anti-inflammatory, even just thinking just from the topical anti-inflammatory perspective, it's quite close to the surface, so we know probably going to get some more perfusion compared to some deeper tissues. Do you see a
Mm.
symptom benefit to wraps or anti-inflammatories, oral, even oral, not topical in these situations that might benefit being able to control loading? I'm thinking especially the people that are really irritated. Or do you see you almost have to go to a point if someone's super irritated, you're not getting them calm, even looking at something like immobilization in a boot for a short period?
Yeah, look, I think that's a really good question. It's so it goes to the question of what, how do we actually control pain in these people, and is pain the same as the fluid? And that's sort of where my thinking goes. And do we need to control the fluid to get rid of the pain? And my impression is that we don't. So it's just like any other pathology that we have around the foot and ankle and anywhere else. There's not a strong relationship between what we see on the scans and pain. Pain is far more complex than what we're seeing on scans, even if it is fluid, and even if our impression is that it is acute. Um, it's it's really common for me to see in practice that people with tibialis posterior, their pain gets much better, the fluid's still there. I'm thinking of someone that I'm treating at the moment who has got quite a severe, very, very severe tibialis posterior problem. And she has got control of the symptoms after a few weeks. But her, if I look at her on scans when she comes in, um, and now I'm not advocating serial imaging, but it is sometimes interesting for me to look at them over time just to see how the fluid um, is responding, because then I can answer questions that guys like you ask me on podcasts about, tricky things like this. But it doesn't really change your management. It's sort of, for me, reinforced that we are treating pain, and the fluid may not change. It does change over time. If I look at her in 6 months, it probably will have gone down once we've got complete control of her problem. But it's not the thing that changes in the short term, whereas the pain does. So this and it just then speaks to how complex pain is, and it's not just about the tissues; it's about other things as well. And that's so. I think what we've done with her, as an example, to get control of her pain, is we have really tried in the short term. She was one of those people that had extreme pain with walking, extreme pain with calf raises, just really painful every day. So we just shut down her activity, her walking, as much as possible to minimal walking. We did that for a good few weeks. We also did, she's got orthotics that she uses, appropriate footwear. Uh, we then did the hiradoid and the topical anti-inflammatory. I then would ultrasound her when she would do that for a week. So sometimes I'll just get them to come pop in and do an ultrasound scan just to see how that's going. Because I like, if I'm going to get them to do something like that, it's good to have the evidence that it's actually making a difference. If it's not after 2 weeks, I just say, look, just stop it. Don't worry about it. You've done, you've sat there for 2 weeks getting cream all over yourself at night time and sleeping in a very uncomfortable way. Enough's enough. Just stop. And it doesn't seem to be making a difference. So I then focus on the other strategies. Now, the boot will come into it if you can't get control of the symptoms after 2 or 3 weeks of doing that approach. You might consider a part-time boot. Say they've got a job where they just can't get off their feet, they're a chef or they're a nurse or something like that, then I would consider a part-time boot to try and get the symptoms down. But obviously you want to use that judiciously, given the potential negative effects it can have on strength.
Mm. There's so much there that you've talked about. I'm trying to sort of just make sure, like just absorbing it all in. And I think, yeah, you sort of touching on, that difference between pathology and pain. And I think, we've seen like the Cook Purdom model from 2016, where they delineated, pain from function from pathology, which I think you're highlighting is really relevant here. The other thing is, it's almost like you've caught up, you've listened to my podcast as well, because the very last episode I had with Darcy talking about technology, we're talking specifically about POCUS, and I think you've really highlighted exactly its use, which is
mm,
it's not always about serial imaging, but it
mm,
is something that's really helpful to be
mm,
able to go, I do something and I get a change. And you can sort of see it over time. And I guess there is a
mm,
significant benefit as well to being able to go to your patient and go, we haven't changed this, but you've had a significant benefit. And so, sometimes I
mm,
have a posterior tibial tendon or patient with posterior tibial tendinopathy at the moment, and yeah, the imaging is quite an anchor for her. She's come to me with imaging
mm,
already, and
mm,
then she's gone off and done all
mm,
this research, and that's become a significant anchor for her. So to be able to sort of go, hey,
mm,
we don't have to send you back for a $200 ultrasound or whatever to understand, and then the radiologist, rightly so, writing a
mm,
report saying, severe changes in this and that, and freaks
mm,
people out. You can sort of have that
mm,
more nuanced conversation. So I think that's
mm,
fantastic.
mm,
I like the part-time
mm.
boot as well.
Yeah,
Sorry, you're gonna comment.
I was just going to say, yeah, we can have a really long conversation about point of care ultrasound, because it is you do have to ask yourself, why are you doing it? It's doesn't offer it doesn't offer the benefits that most people, or at least most patients, think. It's because patients sort of come in and they see that you do the ultrasound and they think, oh, this is great, they're going to be able to diagnose it. But as we know, it's not about that at all. It's not about, it doesn't really help diagnosis that much, and it doesn't even help follow up at all. But it is, as you say, the ability to reassure people, to put the scan into context, and I think also to see whether you are having some of these effects that you think you're having. So I think I'd completely agree with that. Yeah.
It's very much, it's much more about us than it is about the patient.
I think that's true, but it is also about the patient if you can reassure them, because it's that next level of saying, okay, so the scan you've had is not the answer that you think it is, and putting that into context when it comes from someone who's done the scan themselves, it has a bit more weight, because the patients think, this guy's done the scan, but he's also told me it's not important. So I think that it does have some level of extra sort of weight for the patient. So it's that reassurance factor that is really powerful.
No, that's a very good point, because I do definitely see that where people are like, when I look at the scan outside of it and they go, this is what we're seeing, what we're doing, and yeah, I can see how much more powerful it is, especially when you get, every now and then you get a
Mm,
rogue radiologist
mm,
drop a comment or two. You talked about
yeah.
part time boot, which I thought an interesting sort of point, because a lot of the ways that we think about immobilization is you're immobilized and it's got to heal, or you're not immobilized and you're loading it.
Mm,
But I guess what you're implying
mm,
is that realistically, if we think load is much more about how we get it, it under control rather than healing, to sort of launch
mm,
off that
mm,
discussion about fluid, and you
mm,
using it more as a tool to say, here's your periods of high load, how do we control it for
mm,
that period of time, and then you loading it when you can otherwise. And I
mm,
guess
mm,
my big sort of question would be, how long would you do that for, and what happens if someone is
mm,
struggling to get control of their symptoms, where we're trying to modify all the load, but the boot's the only thing that's keeping them settled.
Yeah. So basically, I think the most important thing is to have a conversation with the patient initially, to say, we don't have any mechanism to know how long it's going to take to settle, but we think, if you can control, I think I think knowledge is really important for the patient to know, these are the things that are actually aggravating your problem. It is the standing, it is the walking, it's all those things that you're doing. So Then it's up to them to look at how much of those things they're doing across their week. And it might be that they keep a diary over the coming weeks. It might be that they can think back and decide, what things they're doing, and then it's modifying incrementally the things they're doing, and that might involve a boot for some of the things they can't avoid if their pain's very high. Uh, Once you've done that with a patient, it's sort of an empowering thing because then they're in control of, and they understand what they're doing. And then it's about, okay, so how long do we need to do this for? And the thing with that is just trying to monitor. So if they're still doing some walking, if they're still doing some activities that are painful, because they're sort of reasonably painful and not too painful, you monitor the pain with those activities and you see how much the pain is. And if it's getting better, say they still maintain some walking or standing, you would expect to see the pain with those activities improve or completely go over time. And then you know you're on the right track. If they're not doing stuff where they can monitor with their usual activities, you get them to monitor with a load test. So it might be that they, every week or every 2 or 3 days, they drop their heel and they do 3 or 4 calf raises, which are really painful for them, but it gives you an idea to monitor. So they're the sort of things that I try and do. Just try and get them to modify their load themselves and then get some sort of load test that they can monitor themselves over time. So then they should be hopefully coming into you and saying, I think I'm ready to progress now because all these signs are getting better.
It's you're if I'm picking up sort of the hint behind what you're saying is going to be, if you're controlling all the load, they should be getting better. And if you've got this boot and they're using it, they should be settling it down, and then you should be able to be loading it up. And I'm guessing if they're in real struggle town, they've dropped all their load, they've gotten it under control with with whatever load management tool they have. Let's say they get to the boot and then they're really struggling. They're at that boot, they're struggling to then
Mm,
reload. I'm guessing there's going to be a
mm,
question there about your overall management, and
mm.
that's where like orthotics, shoes, and other things
Yes,
come in. Or
yes,
I'm guessing
yeah,
there'd be a differential diagnosis comes in as well, where you're going, well,
mm,
if I've done all the
mm,
things and they're not getting better,
mm,
I'm guessing you'd start to
yeah,
question whether there's something else going on because you're
yeah,
sort of
yeah.
doing all the things
I,
that should be helpful.
yes, I think that's right. Yeah. So, um, at the start of the assessment, you'd also be looking at all the other things that could be influencing their problem. So it could be things like um, there might be weight issues, for example, and that's really common with this demographic as well. And there might be physical activity issues. They might be really deconditioned, really low in their physical activity in general. There might be issues with stress, life stress, or other factors. It could be sleep or other things that are inputting into their pain. So at the start, you're sort of looking at trying to address. Whilst they're in the boot, say you do go the part-time boot option, you're then looking at all these other things. So then I'd be getting them onto a physical activity program. I'd be talking about ways that they can improve their weight or at least their fitness, addressing metabolic factors. And that's an opportunity that you can do when they're in the boot. So it's sort of a multifactorial thing. Um, and because we know that it's not just about the loading, because you're right, they might do the boot for 6 weeks, part-time boot for 3 weeks or whatever it is, and or they might do no boot but just offloading, load modification for 3 weeks, and then they're no better for it if you're not getting those other factors under control as well, or at least making some effort. Now we all know those other factors are really, really hard to address. Some of those lifestyle factors are really difficult, but I think it's important that we at least have the conversation and guide people towards where they can get help for some of these things, as part of that multimodal management that we offer. But then it might also be things like orthotics, and it might be things like footwear and other interventions that we look at that point as well.
Yeah, and that's it's so interesting, sort of what you've talked about, because it's something that I talk about a bit, especially to younger clinicians. You know, the overall management of the patient, and you know, you being a guide, or sometimes I call it being a coach, because there are things that you can
Mm,
do. I mean, if you've got a sports player that comes in and you know, okay, you know, this is a problem, and they need to work on all these other things that are, you know, in their life. You know, they come in and, you know, you can tell
mm,
there's life stress, you can tell they're not sleeping, they can tell there's stuff going on. You know, you're not, as a coach, you're helping them on the field, you're helping them with their skills, you're helping with them their
mm,
training, but
mm,
you are also at the same
mm,
time there as a guidance. And to I find
mm,
sometimes people sort of look at it and go, oh, you know,
mm,
just giving them the generic advice and here's the generic referral. But
mm,
I can see there's a lot of room
mm,
for us to be able to go, especially because so many of these people come to us with problems, having
mm.
tried to lose weight, having tried to,
Yep,
you know, often they get injured because they've started
yep.
moving more or exercising more, and this has come up.
Mm,
So I
mm,
can see
mm,
there's a lot of crossover with looking at how you're helping them with load management, and how you can say, okay, if we, you know,
mm.
be a very specific guide to say this is what you can do if you're trying to increase your exercise to control metabolic factors. This is how you can manage, you know, maybe some of
Yep.
your night pain symptoms. That's
Mm,
going to help you better sleep. Like
mm,
I guess it's I think probably a good point to make here, because yeah, I think when we talk about sleep, when we talk about weight, when we talk about a lot of these things, we sort of look at it as a patient problem, not so much how
mm,
we use our knowledge to help them and coach them into being able
mm.
to do more. And I'm guessing you would agree with that.
Yeah, yeah, I think so. I think trying to we might not have all the answers and all the solutions to those problems because they are difficult problems, but it is about trying to make the connection for the patient. I think it's our job to say, look, these things might be contributing. It's not for us to say, oh, this is your problem. You know, you're overweight and you've got, elevated cholesterol. That's your problem. But just trying to draw the link that this could be contributing, have a think about this and reflect on that. And then it's the patient's got to be self motivated to then have go down that path. And it might be us that guide them to resources or to the professionals they need help from, or it could be us that help with a physical activity plan. But I think from our skill set, it's probably going to be, then, using some other professionals to help because they're sort of things that often we need help with. Some patients that are really motivated, you get them on a physical activity plan and they do really well. But you're right, most people have tried to lose weight multiple times. So just telling them that weight loss is going to be helpful is not really helpful for them. So it's sort of, I guess the approach that I take is I try and emphasize the importance for their tendon problem. And that's sort of what I can do because I can say, look, this is something that's probably a real contributor because you've had this for a long time. You haven't responded to exercise multiple times. Um, Reflect on that, and we can talk about strategies, and I can help and guide you um, along the way. So I think it's just making that a more of a priority.
Yeah, I think this is the sort of the time when these sort of topics come up that I sort of highlight. You know, so I'm a healthy at every size aligned practitioner, which means, you know, I'm generally not recommending weight loss, and specifically, and part of the reason is that the research that I've read and understand is that when we tell someone to lose weight, they try to lose weight. Well, losing weight's a hard goal, but it's what we see is when we don't have a weight based goal, people are ironically more likely to lose weight. So when you focus
Mm,
on healthy behaviors,
mm,
they lose more weight than if you told them to lose
mm,
weight. But the
mm,
other thing that we see
mm,
as well is that there's significant improvement in health related factors. So, you know, we think about metabolic factors. We don't have to lose weight to improve metabolic markers.
mm.
We don't have to lose
Yes,
weight to be eating
exactly.
better. So I guess
Yeah, yeah,
I'm guessing you would agree here
yeah,
as well, is that we're really, with this advice, potentially trying to create an environment that overall
mm,
helps healing. It's not a dose response relationship. You lose X weight, you'll get this benefit, where, like we
mm,
sometimes see in what people sort of talk about with osteoarthritis, lose X% of your weight, which I think is a dubious
mm,
dubious recommendation anyway. But I'm guessing that's sort of what we're getting at with back to
mm,
sort of the coaching, is that we can sort of highlight, like, the player, hey, you need to be
mm,
getting better sleep, you need to be eating better. We're seeing your on-field performance be a bit average.
mm,
These are the things that I think are helping.
mm.
I mean, obviously we can give them direct
Yep.
advice of, this is what you should be doing in this situation, this is how you could be training better as a coach. But yeah, we've got that nice advice, and they don't have to be, like the players, if they're just
Mm.
getting a little bit more sleep, a little bit more this, a little bit more that, that can be the change, rather than a wholesale
Yeah.
revolution of their life.
Yeah, that's a really good point. I think that's the point that I try and make with people. It's not, we're not talking about overhauling your whole life. It's not, you don't have to change everything. It's like, think about it as levers that you can pull, and you can pull one or two of them to get a good effect. You don't have to change everything. So it might be diet, it might be lifestyle factors, it might be sleep, it might be doing more physical activity. It could be a combination. The more you do, probably the more successful you'll be. But um, I think that's a really good point. You don't have to overhaul your life, because people can be very daunted by, oh, look at, you've got all these things you've got to change, and you've got to improve this and that and the other. And biopsychosocial assessments tend to lead to, it's a bit of doom and gloom. Everything is bad, and what are you gonna what are you gonna address first? It's but you don't have to address everything. You just have to try different things, and it's then up to the patient in a more patient centered way to think about what first of all what they think is relevant, and then what they think they want to change as well.
Changing tacks here, sort of, one of the things that we sort of mentioned right at the start that we haven't really sort of jumped in on, when we're talking about populations that it affects, we're talking, more about older patients, where we're getting this potential change in their foot posture. When we looked at adult acquired flat foot deformity, now we're seeing, a change to the terminology to progressively collapsing foot deformity, which is kind of
Mm,
highlighting, from my understanding, that the foot can collapse with and without
mm,
the impact on the posterior tibial tendon. My sort of first
mm,
question about specifically this would be, and what we sometimes see in the research when they're talking about patient populations, is people doing cutting sports, jumping,
mm,
activities that are going to load a tendon more, potentially also getting this condition. And then
mm,
also, yes, the other side is the people with, the progressively collapsing flat foot, with that are older,
mm,
with metabolic diseases, things that make it more likely they get the collapsed foot and they're the impact. I'm guessing
mm,
from what you've said previously that there's not as many people that fall into that first sort of camp of getting an irritation of the
mm,
posterior tibial tendon mainly through sport and activity. And I guess that the follow up for that as well is for the people that you see who are getting the posterior tibial tendinopathy with the foot collapsing, or sorry, with that are older. Are we always seeing foot collapse be a significant
mm.
component, or are you seeing enough people that are getting it just from the metabolic side of things, just from the age side of things? I guess so. My question really sort of revolving around
Mm,
that: are we always seeing it come with
mm,
a
mm.
progressive flat foot change?
Yeah, so I think it is. I guess maybe I wasn't clear enough earlier. I do think there are demographic groups in the younger age group where it's really common, and you mentioned the cutting sports, but also dancing populations and other types of people that experience a lot of dorsiflexion in their movements. So I think I just don't see as many of those ones personally in my practice. I see more of the acquired flat foot, middle to older age people, and I I think the younger ones they would certainly be experiencing tibialis posterior pain without the flat foot component, and some of them don't even have if you look at their static foot posture, it's fine. It's completely not a problem. It's It's not related. It doesn't seem to be clearly related to foot posture, at least statically, in some people. So it could be more dorsiflexion related, as opposed to coronal plane, for some of these people, or a combination of both. Um, but in the older people, it's an interesting presentation because it's one of the ones that I don't know if we have a good handle on it, but it's a bit more of a progressive thing. So some people, the people that do get acquired flat foot, they have a progressive. It's a progressive disease where they progress through stages, and they get eventually to the point of they could get a tear or a rupture in the tibialis posterior tendon. And what we don't really know is what is the time course or the natural history of that. So how does it change over time? So I don't think we can advise people very clearly on, if you've got, say, a problem when you're 50, how's it going to be when you're 60? Is it going to be to the point where it's a bit more torn, or ruptured, or whatever it is? And is there ways that we can prevent that? We just don't know that at the moment. Um, so my approach at the moment is just really trying to restore function, regardless of what stage they're coming in at. They've got a little bit of dropping of their arch, trying to restore as much function. I've had success with people doing that over the years, um, and I can't say whether it slows any progression, um, and I just haven't had the ability to follow people up over decades or 5 or 10 years. But it's different to other tendinopathies. Like, for example, the Achilles is not a progressive problem. So we know that with an Achilles problem, you don't get to the point where you've got some changes and then it can progress to the point of a rupture. That just doesn't happen in Achilles. Whereas in tib post, it does for some people. Now, I think going back to the reasons for that, I think most of it is genetic, and also systemic. So it's systemic factors like being overweight, metabolic factors, and also genetic, biomechanical factors that can't be changed, that probably dictate most of it, as opposed to loading.
Yeah, and I think that's the sort of point, because if we going back to sort of my question at the start, I think what you're sort of talking about is that there's a dorsiflex based problem for younger people and loading, and that's definitely there. But when you were dealing with this older population, it's potentially, once we start developing it, it's on a continuum, and we might
Mm,
not understand exactly where the flat foot component comes in. But if someone's coming in with posterior tibial tendinopathy without a clear traumatic onset, or a clear sort of, something bad happened to cause this, it's a slow progressive, your
mm,
concern immediately will be, this is a progressive condition, it's going to progress. If we're not seeing potentially a flat foot now, we don't know
mm,
if it's going to turn up.
mm,
But at the same time, you've got that warning light on that this could be could be changing, and
mm,
I guess that's
mm,
sort of informing the way that you're managing it. And I guess that sort of fits with how I manage it, where I see it's not the scale we technically use now, but what people would call grade 2, where we're seeing the tendon and
mm.
foot change. My approach has always been, what
Yeah.
I've always been taught is, go super hard, go super aggressive, get it under control, because you don't know
Mm,
how it's going to progress. And I'm
mm,
guessing that's sort of where you're sort of heading to with that point,
mm,
which is, we've got to get it under control
mm.
because we don't know what's happening, what the natural history will be.
Yeah, pretty much. I wouldn't say that I'm too worried though about it progressing, because if you look at if you the other parallel is the shoulder rotator cuff. where we know that rotator cuff is a bit of a progressive tendinopathy as well. We know that it's an age-related tendinopathy, just like tibialis posterior, and it gets to a point where some people develop tears in their rotator cuff, and they can have complete tears, and it just progresses to the point of a complete tear. It's the same with tibialis posterior. I think there's a certain person who's just predisposed to that complete tear, but I do think it's a small proportion. Most people, and even with the cuff, it's the same. If you look at, because in the cuff there is long-term data looking at prospectively how they change, and most people with cuff pathologies, some of them progress over time, but some of them don't, and they're just stable. So it's hard to predict which ones are going to progress and which ones aren't. So it's it's pretty likely they're not going to progress, but some of them might progress. And even regardless, it doesn't, even if they do progress, it doesn't mean they're necessarily going to need surgery or necessarily going to be completely disabled by it. There are still, as you mentioned, the footwear and the orthotic, but also the strengthening and maintaining function in the foot and ankle as well. That can help people, even if they are in that group that does progress.
Mm. Yeah, and I guess that goes back to that sort of point, sort of we're alluding to back to the 2016 Cook model, which is, the delineation between pathology, function, and pain. And I guess what you're highlighting is that if we're consistently at every single point along the way, whether it be, day one or 10 years down the track, we're focusing on function, which is the main output for them. And obviously
Mm,
pain obviously has a relationship with function, but if we're focusing on keeping them functioning, keeping them
mm,
going, that's more likely to, but that's the better place to sit when we have so many
mm.
unknowns than trying to fix the pathology or focusing, and that goes back to that point about your focus as well.
Yeah, and I think a good point to add to that is that you do see people with a complete tear of tib post um, that can still regain decent function. I've got someone at the moment who's got a complete missing absent tib post, um, and he is avoiding surgery and doing quite well. So there's that as well. And that's similar to what we see in rotator cuff. Not everyone with a rotator cuff tear requires surgery. So that's an important point for patients as well. You don't necessarily need to repair or have surgery to if you've got it completely torn. So even if it does progress, you can still maintain function and be able to avoid surgery.
Amazing. I'm thinking now in
Mm.
terms of, we've sort of talked a lot about the pathology and a lot of sort of general sort of concepts. I'm wondering specifically from your experience with management, what would be sort of really sort of the key, and I'm thinking really practical sort of key things that you'd be doing that you think kind of get missed. So I'm thinking like specific exercises and progressions. I'm thinking there's common things
Mm.
that you see with orthotics and footwear that maybe
Mm.
get missed or make big changes when they get addressed.
Mm. I think probably from my experience, the most important thing is to probably a couple of things. One is allowing allowing enough time and modifying the activity enough for things to settle down. I think people are often not sort of appreciating how long that takes. And the second thing is the progression of exercise has to be to a point where it really does make a difference. And it is simple things, but it's more just the progression of exercise load. So making sure that calf raises are loaded adequately, and you've got to progress from flat ground to single leg and then single leg over a step when they can tolerate that, because that's often painful. And then you've got to progress to, and that can be quite challenging, even just getting over a step for people. And then you've got to progress to loaded exercise. If they're really weak, I tend to prefer using a seated calf raise option because they can, say you've got someone who's 120 kilos, they're going to really struggle to do their body weight in standing if they're very painful. So you go seated and you can build up gradually. So there's things like that that can be really beneficial for people. So I think it comes down to the progression of load. I use a lot of isometrics as well, but I don't use isometrics so much for pain. I use it for developing tolerance and developing capacity and developing strength in the tendon. So I'll do a lot of isometrics, and I do it throughout the whole rehab phase. It could be for 6 months they're doing it, but we're doing isometrics for 20 seconds, 5 sets of 20 seconds usually I do. And the reason I do 20 seconds and not 45 seconds is because they can hold heavier weight when they're doing 20 seconds because it's not as long, so they get more adaptive response in their tendon. Um, so they can hold heavy weight. So that it's not uncommon for someone with a tib post problem to get to the point where they're doing 20-second holds in a calf on their toes position with say 20, 30, 40 kilos. um, usually with uh, um, either dumbbells, or if the weight's getting quite heavy, they'll be getting into a Smith machine. So those types of things can be really, really beneficial. Um, Using load in a way that can build capacity uh, can be really, really good. And it's just finding different ways they can load that is not too painful for them. So that's probably the key thing I think that I find I'm adding in when I'm seeing people as a second opinion.
That's yeah. This my strength and conditioning part of me. Is very happy with that, and because that's funnily enough, sort of been my sort of inkling as well with a lot of people, trying to get back to running or trying to back to a lot of exercises is still doing
Mm,
isometrics, but it's exactly that. It's isometrics. And I mean, I've always focused on sort of different, positions, but yeah, that's really good to
mm,
confirm because that's not something that I've been thinking from a functional perspective and trying to improve their tendons, performance ability. But I guess it's really good to hear that it's you're seeing that from the perspective of actually being able to get an outcome for the tendon itself.
mm,
So that's really cool.
mm.
Any comments? I guess you probably don't deal with the orthotics as much, um,
Mm.
but anything on the orthotic side of things that you see that you sort of like, oh, works better or doesn't work as well.
Um, Probably not from that perspective, but I do think that orthotics are an important part of management overall for tib post, and it's probably one of the tendons that I would often, if they're not, they usually already have a podiatrist and they're seeing a podiatrist, but if they haven't, then I would go down the path of referring them to a podiatrist routinely for tib post because it is one of the ones they will get benefit from having that orthotic, even if it's a short term thing or a long term thing. But as they progress through the stages, then they definitely need footwear and orthotic advice. So I think that is something that people should consider. But I couldn't comment on the specifics of which ones uh, have been sort of more effective or less effective.
So we're getting sort of towards the end of the hour, and I'm very aware of your time and not running too far over. So I guess sort of quick fire sort of questions sort of at the
Mhm.
end for you, because I know we can keep sort of talking. My understanding, Shockwave doesn't have a lot of specific evidence in the posterior tibial tendon. Um, Quick fire, is it something, yay or nay for you in management of the condition, and any sort of bits of advice if we're going to consider it?
I think my advice is spend most of your time doing load modification and exercise and education. And that's where you're going to get the most long term benefit. Shockwave may fit into the short term, but the evidence is really lacking at the moment. It's not something that I would spend a lot of time on. Certainly not taking away from the core things that you want to deliver.
Cool. I think that's a great sort of encapsulation. Um, Sort of putting words to what my gut feel is. Um, PRP.
Um, PRP, we know we don't have any evidence in the tibials posterior, but we do know from other areas there's quite strong evidence that it is not effective. So uh, it's probably a very, 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 very last resort. But I try and steer patients towards the evidence to make their own mind up. But the evidence is pretty compelling that it doesn't work.
Okay, cool. In terms of decision making around when you would consider a surgical opinion, is there a point, or are there things where you sort of go, oh, I think we should get some help on this one, or at least get someone to look at it from that perspective?
I think there's no harm in involving a surgeon at some point along the process, especially more progressive, um, if they've got more progressive changes and the flat foot. Uh, However, um, and especially if they've got joints and other things happening as well. But my recommendation usually is, and I think most surgeons, I'm not sure, I can't speak for surgeons, I'm not a surgeon, but I think most surgeons would be possibly consistent with this, and that is, it is pretty major surgery, the reconstruction that people do. Um, you want to sort of avoid it if you can. If you've tried a good go at exercise for a few months and other approaches like we've talked about, and it hasn't really helped at all, then that is probably the time to then consider more seriously going down that path. I don't know. I'd say most surgeons would be consistent with that, but yeah, that's sort of what I would probably advise people.
Yeah, and that's definitely my experience as well. Because most of the time when we're at a surgical opinion, it seems to be the surgeons are like, okay, we want to make a very large change to your foot posture. Because I think we know that
Mm,
tendon
mm,
specific surgery is not super effective, so you have to kind of
mm,
change the internal mechanics, and yeah, it's a very long recovery. And if
mm,
it's not going to be,
mm,
if they're worried about the effectiveness, I don't want to put someone through 6 months.
mm.
It's a number one way, I think, to piss someone off.
Absolutely, yeah. Most people are scared off when the surgeon describes what they're going to do.
Yeah.
I've had quite a few patients come in and say, "Oh, he's gonna like change all these things in my foot, and he's going to move tendons."
Mm.
And people get quite sort of they start to take their rehab a bit more seriously when they hear
So
that.
that's what I'm hearing. It's like when things aren't going well, go to the surgeon and get them to describe what the end stage is.
Exactly. It's a good way to get some adherence.
I think we've had a fantastic discussion. I think when you started and you were like, oh, there's actually not as many differences about this tendon. I'm like, wow, am I barking up the wrong tree? Having a whole chat just about the post tib, but I think there's been so many things in there um, that have been, I think, incredibly helpful for me to think about, and hopefully for everyone else. I'm wondering if there's anything as part
Yeah.
of our discussion that
Yeah.
you would add, that you've thought of, that that's come up for you that we haven't explicitly discussed, or you know your sort of key takeaway, if people are going to leave with one thing to think about.
I think we've covered lots of ground. I agree. I think the key thing is probably to focus on the whole person. Think about the whole person and try and empower them as much as possible in all the things that could be contributing and dealing with all those things. Because, like any musculoskeletal condition, that they are hard to manage, and especially when you've got the difficult person who's got lots of contributing factors, and it's trying to change as many of those different levers or factors as you possibly can to get a positive outcome.
Mm. I love that. I love that. That really sits. As someone who does a lot of psych informed practice and narrative medicine, I think that really sits quite nicely with me. After having a very deep chat for an hour about the pathology itself, to finish with that kind of
Yeah.
takeaway point, I think's a nice sort of reflection of yeah, like you said, biopsychosocial practice. So if people have really liked this discussion, they want to hear more from you, they want to see more from you, where can people find you? Is there anything that you specifically as well want to plug?
Yeah, thank you. I've got a website which is tendinopathy site, and patients can track me down for. I do telehealth and other stuff, but also courses on tendinopathy as well. So that's probably the best place.
Amazing. Amazing. Thank you so much for your time.
Fantastic. Thanks for having me, Alex. That was fun. That was really good.
Yeah, this has been fun for me as well. Thanks, guys, for tuning in. This has been the Rehab Podiatrist podcast. If you join this episode, you can subscribe on every podcast platform. If you want to follow me, you can find me on all social media, the Rehab Podiatrist podcast. But until next time, thank you.